Okay, the screen is shared.
Yes, ma'am. Is it?
Okay, fine. Yeah. Uh, so good evening to all of you. Uh, this is a topic that I thought is not emphasized in uh, our training, and this is something that we deal with every day. That is why I chose to talk on this topic, even for the DNB classes that I take online. And this is about the interpretation of LFT in the clinical context. The first thing I want to say is that no investigation makes sense outside the clinical context. If you don't know the patient, beginning with an investigation will take you to the wrong side. So always keep the patient in mind and then interpret the LFT. That is why this whole uh, class that I put together are all in the form of cases. I'll give you a problem, then I'll give you the LFT, and then you have to answer what is the diagnosis. Okay. So in this class, we want to identify the variations in the LFT to understand the clinical implications of these changes and to make a unified final diagnosis based on clinical uh, history, examination, and the LFT. So it's a case-based learning. So I want you all to be interactive and please answer on the chat box. And based on that, I will keep asking the questions. Okay, so we start with the first case. 50-year-old lady comes with right hypochondrial colicky pain and jaundice since 5 days. This is the LFT. What is the diagnosis? So again, 54-year-old lady, right hypochondrial colicky pain, jaundice since 5 days. That is the LFT. Okay. You can look at the LFT and then answer what do you think is the diagnosis. I don't see any answers. Is somebody typing? Okay. Oh, couldn't hear. Oh,
It's audible, ma'am.
it's
It's audible.
audible. Okay, right. Okay, so somebody is writing obstructive jaundice. Hmm. Okay, right. Okay, so you think it's an obstructive jaundice, but with that history, what is the diagnosis? Okay, somebody is calling it a cholestatic diagnosis. I want a little more specific. Okay, you're calling it a cholecystitis. Okay, okay, there's no fever there, but anyway. Okay, so let's look at 1 minute. Yeah. Okay, there are few abnormalities in this which I want you to focus on. The first thing is that you definitely have a bilirubinemia, and this is a direct bilirubinemia because most of the bilirubin is direct. There is secondly a high alkaline phosphatase, and thirdly there is a PTINR which is deranged, right? So putting together that is a direct hyperbilirubinemia with an increased alkaline phosphatase, you think it is an obstructive jaundice, and with that history probably she has got gallstones and that is a biliary colic. There is a PTINR which is deranged that we will talk about. Okay, fine. Now let's look at the next problem. 65-year-old man comes with high colored urine and pale colored stools since 3 months. He has lost significant weight in the last 3 months, has a pain in the umbilical region radiating to the back. He has itching. That's the LFT. What is the diagnosis? Yeah? What's the diagnosis, please? Okay. Somebody is writing this is an obstructive jaundice with a periampullary CA. How do you know it's periampullary now? If I had put as a melena, then you could have called it periampullary, right? Otherwise, we cannot, right? Yes, it's an obstructive jaundice. And again, the same three abnormalities are there. There is a direct bilirubinemia, there is a high alkaline phosphatase, and there is a PTINR, which is abnormal. But what's the diagnosis here? Diagnosis here is what? Obstructive jaundice due to? Anybody? Am I not seeing on the chat box? Okay. Okay, that's not a pancreatitis. It's probably a CA pancreas because of the weight loss and those things. That is why. Okay, fine. The rest of things are the same. So if you look at the cause of obstructive jaundice, the two main causes is what I put it up there, the gallstones, and you can have a cholecystitis, cholangitis, whatever, and a CA pancreas, right? Okay, look at the causes of obstructive jaundice. So we have lithiasis, uncomplicated, which can be just a colic, or complicated causing biliary pancreatitis, and also acute cholangitis. And then obstructive causes like pancreas. The obstruction can come at the gallbladder. Also, you can have a cholangiocarcinoma. You can have an ampulla of Vater tumor, periampullary, which can give rise to whatever. And these patients, because it's close to the gut, they can have even a melena. Bile duct can be obstructed by many causes, stricture, worms, all kinds of things. And metastasis to the perihilar nodes, because everything what we are talking about is an extrahepatic biliary obstruction. Are we clear? Everything is extrahepatic. And you can have a biliary stricture, like we say, primary sclerosing cholangitis. And then after invasive procedures, you do an ERCP and then you get a problem. Chronic pancreatitis can also involve the distal bile duct, etc., etc. And AIDS, cholangiopathy, ascaris lumbricoides, liver flukes. This is the whole list of extrahepatic biliary obstruction. The most important causes are the first two, and they all present with an LFT, which suggests a direct hyperbilirubinemia with an increased alkaline phosphatase. Of course, the best investigation for cholelithiasis is an ultrasound, because it can show the presence of the stone, the mobility of the stone, where it is, etc., etc. So that's the best. But for a CA pancreas, you'd probably have to do a CT scan, because a CA pancreas is a retroperitoneal structure. So this is a CA pancreas showing you the presence of the dilated CBD and the intrahepatic duct dilatation, and that is the mass there. So investigations will depend upon what you think is the diagnosis. So looking at the LFT is not one size fits all. You have to choose your investigation. Now let's answer a few questions. Why is the prothrombin time prolonged in these patients? Why is it prolonged? Go on, please. Why is the prothrombin time prolonged in these patients? Yeah? Anybody? Okay. Okay, somebody is saying vitamin K obstructive, vitamin K dependent clotting factor production obstructed. Sorry, so it's not moving. Okay, the vitamin K dependent factors are 2, 7, 9, and 10. And in obstructive jaundice, vitamin K is not absorbed, being a fat soluble vitamin. It requires the presence of bile for absorption. And will this PT get corrected when you give vitamin K? Will it get corrected if you give vitamin K? Somebody says no. Anybody? It will, because you don't have a problem with the liver. You only have a problem with the absorption of the vitamin K. So this will get corrected when you give vitamin K supplementation as injections. Okay. Let's go on to the next one. 30-year-old lady comes with jaundice and vomiting of a month, and this is her LFT. So again, you have a direct hyperbilirubinemia. You have all these things. Yeah. And her ultrasound abdomen and CT abdomen is normal. What are your possibilities? Yeah. Ultrasound and CT are normal. This is a lady, 30 years old, jaundice and vomiting of a month. That's her LFT. Somebody is saying, is it an OC pill use? Possible. Okay. So again, you got a direct bilirubinemia, you got an alkaline phosphatase which is raised. There's only few differences that you have to make out. The rise in alkaline phosphatase is not as high as in an extrahepatic. Generally, we say if it's more than 3 times higher, it's likely to be, I didn't say this lady is pregnant, okay? But anyway, it's likely to be that the obstruction is extrahepatic if the alkaline phosphatase is more than 3 times abnormal. But if you do not have a very high alkaline phosphatase and you have finished your imaging, okay, you're not getting an, intrahepatic duct dilatation, those things you're not having. So then it could be an intrahepatic this thing, could be drug induced, like somebody said OC pills, possible. Okay, there are other possibilities which I will discuss. Let's go on to the next one. 30-year-old lady develops intense pruritus in the 32nd week of pregnancy. Now, this lady is pregnant, okay? That is her LFT. So, I want you to look at her LFT and then tell me what investigation is needed. Yeah, anybody? Serum ammonia. What? Acute cholestasis of pregnancy. Yeah, ANA you want to do. Okay. I would ask for a bile acids. Why would you ask for a bile acids? Why would we ask for a bile acids? This is pregnancy associated intrahepatic cholestasis, right? So when you look at an intrahepatic cholestasis, one is definitely hormonal. All the sex hormones, the steroid hormones, all of them are causes of intrahepatic cholestasis. And there are many other drugs, among which you'll have your chlorpromazine, chlorpropamide, erythromycin. There are many drugs which can cause, out of which the sex steroids are probably the most important. In a pregnancy, because of the hormonal, the exact reason why you get pregnancy-associated intrahepatic cholestasis is not known, but there are many reasons which are postulated. One of them is that the increase in the hormones are causing intrahepatic cholestasis. And you would ask for a bile acids, which will be more than 10. And then these people will respond to your ursodeoxycholic acid. Okay, fine. So again, this is an obstructive jaundice, but the ALP is not very high. In the context of a person who is pregnant, this pregnancy-associated intrahepatic cholestasis usually begins in the end of the second trimester and in the third trimester. So that is why we think that in the context of this, it could be intrahepatic cholestasis. You can have many other things in pregnancy. You can have, recurrent cholestasis of pregnancy. You can have acute liver cell failure of pregnancy. There are so many other causes. But these things do not suggest that. That is why we are saying that we should ask. Okay. Right. Let's go on to the next one. Okay. 35-year-old lady coming with severe itching and fatigue of 6 months duration. 35-year-old lady, severe itching and fatigue. On examining, she is icteric, hepatomegaly of 4 centimeters. USG shows nothing. Okay. So her LFT, that's her LFT there. Okay. That's her LFT. And what would you think of? She's a 35-year-old lady. She's not pregnant. There is a severe itching and a fatigue of 6 months duration. Okay. Somebody is calling it a PBC. PSC, okay, extrahepatic cholestasis, but your imaging is normal, right? You're not having IHBRD, you don't have an intrahepatic duct dilatation, biliary duct dilation, not there, okay, fine. So you think of a PBC, primary biliary cholangitis, used to be called as primary biliary cirrhosis earlier. Because of the autoimmune pathology, the name was changed to a cholangitis. Nowadays it's called this. There can be an overlap with autoimmune hepatitis. You got a PBC, autoimmune hepatitis, overlap syndromes are there. So they don't have any intrahepatic duct dilatation as such, okay? And they are causes of something like this. So it's a long duration, 6 months duration. Hepatomegaly is there, icterus is there. Icterus may not be a feature. Many times they can actually have not much of an icterus also, and only an increased alkaline phosphatase. It's a spectrum. So it can begin with, but the most important investigation is there. That's your alkaline phosphatase that is telling you that there is something wrong. And of course, if you look at the hands, you may find, what are these? What are these? No, I'm okay, Sankit. Just that I have a sore throat. Am I croaking too much? I don't know. Right. Okay. These are Palmer xanthomas. Okay, right. So the investigation that you would ask for is you'll ask for an ANA, you'll ask for an mitochondrial antibody, and of course, you'll ask for your fasting lipid profile, because we are looking for a abnormal lipid profile in these patients. Okay. So somebody who comes with something that looks like an obstructive jaundice but doesn't have anything much in the liver, and a lady who's coming with 30 to 60 years of age, then we have to think of this. Sometimes they can present only with an alkaline phosphatase increase, where you will be searching all over the place. Okay, but otherwise think of an autoimmune cause. Moving on to the next one. 58-year-old man comes with 6 centimeters hepatomegaly and moderate hemorrhagic ascites with weight loss. Now that is his LFT. Okay, so you got a total bilirubin, direct bilirubin, ALP, and everything else. Okay, fine. So what is that now? Severe weight loss he has got is 6 centimeter hepatomegaly, moderate hemorrhagic ascites. Okay, somebody calls it HCC. Okay. So let's look at here also you got an alkaline phosphatase which is raised. Can you make out? Right. So you can think of two possibilities. One is because it's a hemorrhagic ascent. That's a giveaway, right? That's a huge clue there. So that's a malignancy. Okay. That malignancy can be either, it can be a HCC or it can be secondary. You can have a gastric, colonic, whatever going to the liver causing secondaries. That also will cause an increased alkaline phosphatase. Okay. And that's the bilirubin. I want you to notice the level of alkaline phosphatase and the level of bilirubin. We will come back to it and explain what is happening here. Okay. Next one. 65-year-old man presents with low-grade fever of 2 months duration with significant weight loss. Yes, hepatosplenomegaly, multiple lymph nodes. LFT is, that's the LFT. So, what's the diagnosis here, please? Okay, 45-year-old man, low-grade fever, 2 months duration, significant weight loss, hepatosplenomegaly, multiple lymph nodes. That's the LFT. So what's the diagnosis? Somebody's calling it lymphoma, somebody's calling it TB. Okay, right. Okay, so what is this now? This is an infiltrative liver disease. Okay, it's an infiltrative liver disease. That's what we are looking at. Okay, fine. So let's look at the causes, what I told you. So these are all the causes of intrahepatic cholestasis. Let's look at the problems that we went through. We said it could be because of drugs and toxins, which are causing, like especially the steroid sex hormones, primary biliary cholangitis, primary sclerosing cholangitis. Okay, fine. And intrahepatic cholestasis of pregnancy. Then benign post-operative cholestasis, which I haven't talked about. Total parenteral nutrition can also cause this. But look at that big chunk that comes here. This one. That is an infiltrative liver disease. Under that comes, like what you all said is absolutely right. The two most important causes of tuberculosis and lymphoma. Okay. These are the two big ones. Okay. Amyloidosis, sarcoidosis are rare. And hepatic abscess also you can make out by other means. But tuberculosis and lymphoma are the two things which you said are correct. Okay. Which are very important. Metastatic carcinoma of the liver, liver allograft rejection, other IgG4 cholangiopathy and all that is known. Alcohol-induced hepatitis is, we'll talk about it later, and sickle cell, not a very important cause. So you look at all these causes, these are all causes of intrahepatic cholestasis. So first we talked about extrahepatic, now we are talking about intrahepatic. Now I want you to notice a few things. The disconnect between the ALP and the bilirubin. In an extrahepatic cholestasis, if you remember our CA pancreas patient and our this biliary colic lady, they all have good amount of bilirubin and a good amount of ALP. When you do not get that much bilirubin for that ALP, you have an ALP of 840, but a bilirubin is 3. They're not going hand in hand, right? Then you have to think that it is probably a granulomatous hepatitis and those causes the hepatoma and secondaries, which are the most important causes. So when you're looking at an LFT and not finding much of bilirubin, but are having a high ALP, then you think of one of these as your causes. Okay. So that's an important learning that you have to make from the LFT. Moving on to the next part. Okay. 25-year-old man with fever of 1 week, loss of appetite, vomiting, that is his LFT. Very, very simple LFT. Look at it and tell me what it shows. 25-year-old man with fever of 1 week, loss of appetite. Acute viral hepatitis. Yeah, correct. It's an acute viral hepatitis. Very simple, isn't it? Okay. So where do we get the viral hepatitis? That is the 4-digit enzyme. When you have a 4-digit enzyme, okay, generally in enzymes of more than 10 times normal is enough for you. But if you have a 4-digit enzymes like what I gave you, then definitely it's a viral hepatitis that we have to think of as a one cause. Okay. Other things can also be there, right? And you get a direct hyperbilirubinemia. The ALP is not very high. These are all right. The PTINR is a reflection of the poor liver function. Okay. So you have to look for hepatitis A, B. C is not common for an acute viral hepatitis. Okay. Now, one thing we must remember, all hepatic conditions cause more direct than indirect bilirubin rise. Why is that? Why do you get more of the liver goes? Both functions must go, right? The conjugation function and the excretion function, both must go. But why do you get more of direct than indirect? Why do you get more of direct than indirect? Anybody? Yeah? Because, okay. No, actually the conjugative function is okay. The excretory function is more affected. In any liver disease, the excretory function is more affected than the conjugative function. So the liver has both the functions. That is why, because the excretion is less, that's why the direct bilirubin is always more than 50%. There's always a debate how much of bilirubin should be direct for you to call direct hyperbilirubinemia. All kinds of books say all kinds of things. And sometimes we'll be arguing about a 2 bilirubin is one direct. That kind of hair splitting doesn't work in real life. If it's a bilirubin itself is so small, you can't go and hair split and nitpick and say this is direct or this is indirect. It's substantial. Then yes, in any liver condition, anywhere where the liver is abnormal, the direct bilirubin is common. So in obstructive jaundice and in hepatic jaundice, there is a direct hyperbilirubinemia. In hemolytic jaundice, there is an indirect. Okay, fine. Let's go to this. 1 week later, this patient feels better. Appetite improves. He, however, complains of itching and has pale stools. That is his LFT. That is his LFT. So what do you think has happened? What do you think has happened now? Same patient, your viral hepatitis patient, enzymes have come down. Can you make out? From 4 digits to 3 digits. Okay. Now he has got appetite is improved. However, he's complaining of itching. Jaundice has become a little worse and he's got pale stools. What is this now? Somebody is writing obstructive jaundice. Improving. This is the cholestatic phase of viral hepatitis. Correct? The cholestatic phase of viral hepatitis because, no. Let's not go there. The cholestatic phase of viral hepatitis is the middle of viral hepatitis. So you have a prodrome, okay, where a patient looks like every viral fever. Then the fever subsides, he gets a jaundice, and then the enzymes start coming down. Okay. Generally, the enzymes go up first and come down. The bilirubin goes up after that and comes down. But what I am talking about is not that. What I am talking about is after the initial phase, there is a middle phase of cholestasis, right? During which there's a swelling of the biliary the hepatocytes, which will cause obstruction, which is an intrahepatic cholestasis. During that time, patient will actually have good appetite. So his actually liver is improving, but he's got itching, got pale stools, etc. And everybody is worried why the jaundice is increasing, which is coming down. Why is it increasing now? Okay. And then, because I'm saying the pale colored stools, this is not just the natural cause, right? What somebody wrote, bilirubin rises later. Correct. First, the enzyme will go up, come down. Bilirubin goes up. After that, it comes down. But because of this clue given here, this is an intrahepatic cholestasis happening in the middle of a viral hepatitis and should be taken as such. And this will improve. Once the color of the stools returns, then this bilirubin will fall, the enzymes will fall, everything will get fine. Okay. Fine. So this is the cholestasis of viral hepatitis, cholestatic phase. After this will come the improving phase. Okay, now look at this one. A patient with acute viral hepatitis becomes drowsy during second week. LFT is 800, 1200. That was his earlier LFT. Now his LFT is 40, 70. Bilirubin has gone up. What's happened now? So this patient came to you with a viral hepatitis. That was his enzymes. You knew he had viral hepatitis. And suddenly in the second week, he becomes drowsy. The enzymes have improved. The enzymes have really improved, right? 40, 70. Bilirubin has gone up. So what's happening? What's happening now? Anybody? Liver is failing, isn't it? This is an acute liver cell failure. This is a liver which has nothing to give to fulminant hepatic failure. There's nothing to give to the blood. No enzyme is coming out. Okay, so this is not an improvement. This is a deterioration. That's why I said it's not the number. Look at the patient. Patient has become drowsy. Is going into hepatic encephalopathy in with a fulminant hepatic failure. Now this man is very very sick. Because if you have an acute liver cell failure in a viral hepatitis, the prognosis is very bad. So that's why this patient is going to be very, very sick. So this fall in enzyme is a shrunken, empty liver. The liver is completely gone. That's why you don't have an enzyme rise. Your bilirubin has gone up, okay, and your patient has become sick. So this is a fulminant hepatic failure or acute liver cell failure happening in the context of a viral hepatitis. Okay, fine, right. Okay. Okay, now look at this. 40-year-old lady with DCM, dilated cardiomyopathy, comes with BP of 80/60. She has bilateral pedal edema, is breathless on oxygen, somewhat drowsy. That's her LFT. That's her LFT. So what is the diagnosis here? Okay, that's an ischemic hepatitis, right? That's an ischemic hepatitis. Remember, in a viral hepatitis, always the ALT, which is higher. Then ischemic hepatitis need not be the ALT. It can be the AST also, which is higher. But in a viral hepatitis, usually the ALT is higher. But this is with the 80/60, your liver is not being perfused or it's too congested. So these people can even flap. I've seen a patient with severe cardiac failure with flapping tremors and such a BP, and then the patient cannot even eat. And then you get her out of the DCM, everything resolves. Okay. So this is an ischemic hepatitis, which also can cause a high liver enzyme. Okay, look at the next one. 20-year-old girl consumed Ratol, yellow phosphorus, because of a fight at home yesterday. Sensorium is normal, LFT is normal. She comes there, everything is normal. What is your advice? LFT is normal, sensorium is normal, patient is okay. She wants to go home. What's your advice? Okay, somebody wants to admit in ICU. Now, why should that be? Somebody wants to monitor. Why should that happen? Okay, because it will rise later, right? So that is why you should never send these yellow phosphorus fellows home, because after 2 days, 3 days, there's a gap where everything looks okay. There's a delayed toxicity which comes in. So you must always admit, need not be in the ICU, can be in the ward, but you must monitor. So on day 4, she vomits, becomes tired. The LFT shows that now. Okay, so this again is a toxin causing your hepatitis. Okay, so this is a toxin-induced hepatitis, and these people do quite badly. So this is why you have to admit these patients and not send them off. These can go into an acute liver cell failure again. So if you look at your causes of very high liver enzymes, you got the viral hepatitis where the ALT is more than the AST. You got the ischemic hepatitis in context, paracetamol poisoning or yellow phosphorus poisoning, whatever poisoning, drugs and toxins, so many are there. All of them can cause 4-digit liver enzyme, and these are all causes of what we call as hepatitis, but each of them has a different etiology. Okay, right. Let's look at the next one. 45-year-old alcoholic comes with jaundice. Wife says he has binge drinking for the past 2 days and then complained of right hypochondrial upper abdominal pain. Is vomiting and fatigue. Now, what is this? What is this? Very simple case. What is this now? 2 days binge drinking, and then that is the liver enzyme. That's an alcoholic hepatitis. It's a no-brainer. I'm not waiting for you to answer. It's an alcoholic hepatitis. What I want you to understand is, usually an alcoholic hepatitis does not cause a rise of enzymes of more than 10 times. So if you have a doubt, the enzymes will be high. Definitely they can be high, but they usually are not more than 400. There's nothing 100% in medicine. This is a general rule. Okay. The second thing is that ratio between the AST and the ALT. As you all know, the 2:1 AST and ALT will be usually in an alcoholic hepatitis. Generally in life, the AST is higher than the ALT in an alcoholic hepatitis. And this is because of two reasons. One is because the AST is increased because of mitochondrial injury that happens, and ALT can be low because of the B6 depletion in alcoholics. So the difference between an alcoholic uh, hepatitis and a viral hepatitis is this, that you get a more AST than ALT. Somebody says 42 bilirubin acute alcohol, very common. In Chennai is full of alcoholics. I'm seeing every time different types of alcoholics coming with all kinds of LFTs. Okay. And I don't know why people drink so much here, but it's very common here. Okay. So they can be very sick. They can be very sick. You will have to do the discriminant index, and you may have to put them on either steroids or pentoxifenone. All those things are there. It's a spectrum. Alcoholic hepatitis can be just chumma drinking and then coming to you with a little jaundice, etc., to hepatic encephalopathy. So patient can be from this end to that end. So depending upon, that's why you calculate the discriminant index and see whether you should take that chance and give the steroid or the pentoxifenone or do something else. Of course, load them with thiamine, etc. But the point is that they can be very sick. Okay, right. So let's go on. Okay, now let's look at this. 34-year-old clerk was diagnosed with TB last fortnight. Started on ATT 5 days ago. Yesterday he started vomiting, lost appetite. That is his LFT. And yeah, so that's very simple. That is ATT-induced hepatitis, isn't it? So if you look at that, again, the most important thing to notice there is the AST is more than the ALT. So in a viral hepatitis, it's always the ALT is more than the AST. But in a drug and toxin-induced hepatitis, the AST can be more than ALT. Now, ATT-induced hepatitis usually comes in the first 2 weeks of starting, and about 90% of the cases come in the first 1 month of starting ATT. But after that also, I have seen a patient in the 7th, 8th month of starting ATT. And the point is, once you have a bilirubinemia, you always have to be very careful. Okay, just the enzyme raise up to 3 times, no symptoms. Up to 3 times with symptom, you have to be careful. But if you have symptoms of vomiting, see, whenever you put ATT, patient must get hunger and all those things. They're not hungry, they're not refusing to eat, then yes, you must stop your ATT because it's got a mortality. Once you get your bilirubinemia, there is a mortality in ATT in this hepatitis. But be very careful. Okay, so you have to stop the ATT and then move on. Okay, right, fine. Okay, so that's a simple case again. Drug-induced hepatitis, most common. You go for the non-hepatotoxic drugs, desensitize after that. So put your levoflox, put your ethambutol, then start with INH and rifampicin one by one or together in whatever dose you want. Desensitize over a week, and then you can put back many times. Okay, so AST more than ALT. Okay, which conditions do we get? Drug-induced hepatitis, alcoholic hepatitis, ischemic hepatitis, and in cirrhosis, which we haven't discussed so far. Okay, but these are the conditions where AST is more than ALT. And of course, if you have some other source of AST, that is different. I'm not talking about that at all. Now, let's look at the GGT. The role of GGT, abstinence, it is not raised. That's why our psychiatrists are very fond of asking for the GGT. The GGT goes up in any obstructive jaundice, okay? But it's more used for finding out whether the man is drinking or not, and doesn't come from bone. That's the advantage. ALP can come from bone, or it can come from your liver. I think MedCAS had a case about an ALP raise in a Paget's disease, which we talked about. So that's different. So that may help to differentiate whether it's coming from bone or it's coming from the liver. Of course, if you have a bilirubinemia, you probably is coming from the liver, the ALP. Okay, then it is not specific. It can go up in many other conditions. Even cardiac failure, GGT can go up. So that's why we really don't respect the GGT so much. It's just a side investigation. Okay, right, fine. Okay, let's go on to the next one. Somebody's asking tropical fever. I'll come to that. Okay. 35-year-old lady comes with loss of appetite and fever of 2 months duration. Read it again. 35-year-old lady comes with loss of appetite and fever of 2 months duration. Jaundice is there, liver is there, spleen is there. That's a LFT. Okay. And hepatitis A, B, C are negative. Now, what is that now? What is that? Okay. Somebody is asking, it is a AIH. Okay. Are you meaning autoimmune hepatitis? Okay. I'll give you one small clue. Okay. There's one clue here. Look at that. The globulin, right? The globulin. You got a very high globulin, 5 globulin there, that if you're missed, then your ESR is a big giveaway. So now the diagnosis is very clear. It's an autoimmune hepatitis. So it looks like an hepatitis. It is like a hepatitis only. You got an AST, ALT, which is raised. ALP can be raised. I've seen a patient with autoimmune hepatitis, 1500 ALP and broken my head over it. Ultimately, it turned out to be nothing much, and it can be an overlap. It can be the PBC overlap that we were talking about, where the ALP can be more. But generally in life, if everything looks like hepatitis, you got a woman, okay, who's got a high globulin, and then there is an ESR which is high, then you better think of an autoimmune hepatitis. So these are your 3 types of autoimmune hepatitis, which you'll all classify. This is scoring system, and this is look at the women preponderance is fantastic in all the 3. Okay, and you do your ANA and your asthma and all those things, or you do it for a type 2, you do anti-LKM, etc. Okay, soluble liver kidney antigen, that you can do. So the diagnosis I'm not going into, but remember that if everything looks like a hepatitis, but she's a woman, and your globulin is high and your ESR is high, then think of an autoimmune hepatitis where viral markers are negative. Okay, so let's go on to the next one. 40-year-old man is brought with fatigue and mild jaundice of 3 months duration. That is the LFT for your 40-year-old man. Fatigue, jaundice, 3 months duration. That's the LFT. Okay, right? PTINR is normal, and that's the LFT, right? So definitely this person is having some amount of liver cell injury is there. So you are okay. That's a big, okay. Somebody said already without the clue. Okay, is SPHAG positive? What do you want to do now? What do you want to do now? That's your LFT. What do you want to do? Core. Why would you do core now? He's a chronic hepatitis B, isn't it? He's got the jaundice of 3 months duration. Already bilirubinemia is there. Okay. No, you will not observe. You definitely have to go for a HPEAG and a HPV DNA quantification. Correct. So you want to do an HPEAG, and based on the HPEAG, whether it is negative or positive, then you take a call whether he's a pre-core mutant or not. So if it's HPEAG negative, it is bad. Even with a lesser level of HPV DNA of 2000 copies, you will treat the patient. But if it's HPEAG positive, then up to 20,000 you can treat. After that, you can treat. So your decision to treat and on the number of copies depends upon whether it's HPEAG positive or negative. So you can't observe. Okay. Now you have to go for a clearance. Okay. So this comes in 3 phases, 3 different things, right? So you got the biochemistry, then you got your microbiology, then you got your histopathology. There can be a disconnect between each of them. But generally in life, when you see a chronic hepatitis B, always ask for your HPEAG and your HPV DNA. Based on that, and of course, you got an enzyme which is high. See, an enzyme of 1.5 times normal itself is suggestive of damage to the liver. But you got a 165. Now that is not the patient you will wait on, because this patient will go into cirrhosis, this patient will go into hepatocellular carcinoma, all those things can happen to him. So that's why you will not wait on this patient. You will ask for your further viral markers, and you will probably have to treat this patient. Okay. So your criteria, you can read up from your the hepatology guidelines that have come out recently. The European hepatology guidelines have come out, and you can look at them and read. But generally in life, remember that HPEAG negative is a bad thing to have. Even with the lesser DNA copies, you will have to treat. Okay, fine. Right. Okay. ASLD guidelines, correct. Okay. So we can this thing. So for the chronic hepatitis, there are many causes. Hepatitis B, C has become much easy to treat. You know, it's like a curable disease. It has become. So you do the genotyping, you do your RNA copies, and then you can treat your this thing depending upon what genotype it is, etc. So C has become very easy. D, of course, is a carrier with the B. Autoimmune hepatitis, this thing is steroids. Drug-induced hepatitis, you stop the drug and desensitize. And of course, Wilson's, alpha-1 antitrypsin, cryptogenic cirrhosis. All these are causes of chronic hepatitis. Okay. So remember, when you have a liver enzyme abnormality, whenever the liver enzymes are abnormal, we know it is hepatitis. We just have to decide which of these hepatitis it is. Is it acute or chronic? If it is chronic, these are your differentials. Okay. Right. An obese 45-year-old diabetic. Okay. 45-year-old diabetic comes with an enlarged liver. So that's his LFT. Yeah. So that's a very simple case. Okay. So all he has is a AST, ALT, which is abnormal. There is a hepatitis. Okay, it's an MAFLD, NASH, what you're calling it, metabol is associated. So MAFLD is the name that has been changed from NAFLD, whatever it is. All this patient is a diabetic, is obese, 2 reasons to have an MAFLD. Of course, look for all the other, metabolic syndrome features and then go ahead and treat. Ask the patient to lose weight. 50-year-old alcoholic comes with distension of abdomen and pedal edema and melena. On examination, he has jaundice, that's the ascites. Spleen is enlarged 4 centimeters. Very, very simple case. That's your LFT. Alcoholic distension of abdomen, from entering the ward only, you can make the diagnosis. Okay, this patient has got this. So what is this LFT showing you? This is a okay, DCLD. Okay, this is DCLD with portal hypertension. Correct. Okay, because I said spleen is enlarged. Now, if you look at this LFT, look at the level of bilirubin, not very high. Look at the enzyme rise, not very high. The ALP near normal or even normal. The most important alteration comes here, the AG reversal, right? The albumin which is produced in the liver is gone, and the globulin is a feature of chronic inflammatory state, okay, which is what the cirrhosis is, okay? So, and the PTINR is abnormal because you have damaged the liver. So that's a cirrhosis, okay? Very simple. The most important thing to remember, it's an unimpressive LFT in a cirrhosis. The age reversal is most important. So remember, the albumin formed in liver disease only after 2 to 3 weeks of the liver disease being present there, because the albumin half-life is about 14 to 21 days. Why is the globulin raised? The globulin is raised because of the chronic irritation, inflammation, whatever in the system. Will this PT get corrected by vitamin K? Will this PT get corrected by vitamin K? No, because the factory is not working, right? It's not a supply problem. The whole factory is shut down. So we give vitamin K to partially correct whatever we can, but it can never be corrected completely because the liver is dysfunctional. When does the bilirubin rise in a cirrhosis? The answer to that is late. Remember, it rises late. So we did see some patients with cirrhosis who got 20 bilirubin and all. I had a patient who was hanging around with us for 2 to 3 weeks. The bilirubin went on rising. That is like an end stage, right? Most of the time, the bilirubin is not raised. 2, 3, 5, like that, or sometimes even very little, okay? So the bilirubin rise is not at all impressive in a cirrhosis, but if it rises, that means enough of the liver is gone there, and a bilirubin rise is a bad thing in a cirrhosis. That's why your child Fuchs criteria is based on those things, okay? Okay, balance, okay, that's a story for a different day. Balance between prothrombotic and antithrombotic features. Okay, you can get a coagulation in the liver disease that I will not talk about now, okay, right. Okay, if ALP increases in a cirrhosis, what would you think of? If ALP increases in a cirrhosis, what would you think of? HCC, correct. You would think of a HCC, right? So if a bilirubin increases very much, the liver enlarges, patient becomes sick, ascites increases, and then the ALP also goes up, think of a HCC, okay? So remember these things in a cirrhosis. Okay, the role of the serum ammonia, I just want to make a mention, may be raised in hepatic encephalopathy, non-specific, unreliable, no correlation with severity. A higher ammonia doesn't mean that he has got a very bad hepatic encephalopathy or anything like that, but can be sometimes very useful in a clinical setting, because sometimes, like I told you, we had a patient with who was very dull, always looking this thing. We never understood what she had, and the bilirubin is not at all raised. There was one globulin raise, and we never thought of cirrhosis. But then She was very dull and always drowsy. All the other metabolic parameters came out normal. There, the ammonia helped us. When we did the ammonia was high, and she was actually flapping, not willing to hold up her hands for a flap also. Once we treated her with, your usual lactulose and rifaximin, she came out very nicely. So remember, you should know when to use your ammonia, and remember it can go up in many things, very non-specific, not related to severity, but sometimes a very useful tool for making a diagnosis. Okay, 30-year-old lady, these are all very simple cases. I'm just going to run through them. 30-year-old lady with fever of 5 days duration, myalgia, vomiting, mildly jaundice, that's her TC, that's her platelet count. What is the diagnosis? She mildly jaundiced. 5 days fever, dengue, correct. It's a dengue. You got a low TC, you got a platelet, right? Okay, next one. 30-year-old electrician was repairing wires after a storm. We had a storm in Chennai, right? In 1 week, he's my own patient. In 1 week, he became jaundiced. That is the LFT. That's a platelet, that's a creatinine. Okay, that's a lepto, isn't it? That's a lepto because he's been running around in the storm. This patient became sick. We had to dialyze him, but he came out after that. Okay, so the ictera hemorrhagica, isn't it? Is there. The subconjunctival hemorrhages you have to look for, and the low platelet with a high creatinine and this thing which is high, you have to think of a lepto, right? Okay, 35-year-old laborer comes with a history of fever of a week's duration, mild jaundice, TC is normal. This thing, creatinine is normal. What is that now? Platelet is low, okay. Mild jaundice is there, creatinine normal. And there is one clue in that LFT. There's one clue, typhus, correct. The scrub typhus. Your clue comes from here. Your clue comes from the alkaline phosphatase, right? So many times in a scrub typhus, there is a jaundice, but then, and a few patients I have diagnosed even in Chennai. Once you strip them, they have one scar sitting in the axilla, one in the groin, somewhere. And just to open that up, you can make a diagnosis. But many times the ALP goes up for not a very clear reason. I remember I had a patient with 1,200 ALP. I was thinking maybe this person has a CA pancreas, which I have missed. But actually, it was only a scrub typhus. It was only a scrub typhus. Patient came out without much of problem. Okay. So, short history is what you have to think here. Okay. It's only a week's duration. Now, this is a chart I prepared for other things, but I just want you to concentrate on the LFT here. So, the dengue, AST-ALT can be raised 2 to 5 times. I have seen even a dengue encephalopathy. Sometimes it can be very high. In a leptospirosis, the bilirubinemia is more impressive. Okay, in the dengue, bilirubin is not much. Yet the bilirubin is more. Scrub typhus, AST, ALP, bilirubin. Malaria, more of bilirubin, can be toxic hepatitis, can be a hemolysis also. Typhoid, all the abnormalities in the LFT are mild. So if you look at the LFT in all these tropical conditions, most important, remember it's a tropical condition. It's a short duration fever. It's an acute febrile illness. In that context, you look at the LFT, look at your platelets, look at your creatinine, then make a diagnosis. Okay, let's move on. 68-year-old man comes with fatigue and backache. Creatinine is 3, hemoglobin is 6. That is the LFT. Huge clues. What is that? Okay, that's a multiple myeloma, right? That's a multiple myeloma. Huge clue from this globulin. From that globulin comes a huge clue. And then you got an anemia, you got a creatinine, okay? So everything there fits, okay? And the ALP not raised like I was discussing in the MedCAS group. You do not have any this thing, okay? ALP will not go up in a myeloma unless you have a fracture. Okay, right, fine. Okay, so that's a multiple myeloma. So that also can be picked up from an LFT. So in medicine, the rules for a very high globulin are only 3 or 4 things that you can count on your fingers. One is HIV, one is myeloma, one is Waldenstrom's, and the last one is SLE. Okay, very high globulin. If you see any autoimmune condition, need not be SLE only. Even autoimmune hemolytic anemia can have a very high globulin. Autoimmune hepatitis can cause. So I wrote there SLE, but it can be any autoimmune condition can have a very high globulin. But remember that when you have a very high globulin or a triple digit ESR, An ESR more than 150. The lab tells you more than 150. You can't even understand what is happening. Remember these things. These are the common things. Okay. Right. 30-year-old lady with fatigue as jaundice. She has normal colored urine. Hemoglobin is 5. Spleen is 3. So that's here. This is a very simple case. So what is this now? There's a huge clue there. The hemoglobin is very low, and then you got hemolysis. There's an indirect hyperbilirubinemia, right? So you got an indirect hyperbilirubinemia. Total bilirubin is this. Direct is not raised. And then you would probably do the LDS, the reti count, the peripheral smear, and then go on to type what is the kind of anemia she has, and then go on with it. Okay. So this jaundice is an indirect. And remember, it's an echoluric jaundice. The color of the urine is normal here. And of course, she has got a anemia jaundice splenomegaly, which is what a hemolytic anemia is. Okay. 28-year-old homemaker with no comorbidities has fever of 3 days duration and vomiting, did not eat, and on routine LFT was done. So obviously she went to a clinic and this is the LFT. What's the diagnosis? Yeah? Malaria. Okay. That's the LFT. Surface smear is normal, right? Fever is gone. Okay, somebody is calling it Gilbert. Yeah, that's a Gilbert, right? That's a Gilbert because you have everything that looks like, in indirect hyperbilirubinemia, you are thinking there is no hemolysis. Okay, the hemoglobin is perfect, the peripheral is normal. These people with Gilberts, remember, they have precipitation of the higher bilirubin with fasting and infection. Okay, so many of my patients with Gilberts have always come, saying that, oh, they got jaundice, and people will put him on that very abnormal diet with no salt, nothing, and they will get more hungry and they'll get more tired, and everybody will say they got jaundice. And many people walk through life trying to do all kinds of diet for a Gilberts, which doesn't require anything. And one of the happiest moments in a patient's life is when he meets us and we tell them, you can eat anything. That's his biggest, the gift that you can give to the patient. So remember that the Gilberts, which looks like indirect but does not have a abnormal peripheral smear. So I'm just going to summarize. Direct bilirubin rise is in cholestasis and hepatic jaundice. Extra or intrahepatic, you have to look at the ALP rise. ALP is much more raised in an extrahepatic. Then you think of these two conditions, gallstones and your CA pancreas and all the other things that you want to think about, go on image. If it is not there, your imaging is normal. Think of the intrahepatic cholestasis for which so many causes I gave you, out of which your infiltrative liver disease is very important and the CA and the HCC is very important. The drugs and toxins and all can come later. If you see a disconnect between the ALP and the bilirubin, think of an infiltrative liver disease. Bilirubin of 800, ALP of 800, bilirubin is 2, 3 and all that, think of that. If you got an 800, you need a 10 on the other side. Right. Enzyme rise, the usual causes, viral, alcohol, drug-induced autoimmune, etc. Many tropical illnesses, LFT can be abnormal. You have to be careful in interpreting. Albumin is low in a chronic liver disease. Remember that. Globulin is high in any chronic inflammation or a malignancy. Indirect bilirubin rise is in hemolytic anemia and in Gilbert's. So the LFT is a gold mine, okay? It's a gold mine. If you know how to read it, it will make a huge impact on the diagnosis and treatment of the patient, okay? So I think I conclude with that. That is the end of class. Thank you.
Yeah, thanks a lot, ma'am. Any questions you can ask? I had two inputs, ma'am. Two
Yeah.
things what I still feel that I realized little later. One, I'll
Yeah.
start with one case that recently I had a boy who was referred to us because ANA came positive. So that was the first story. But the overall his symptom was dysphagia. I think I discussed this case on a MedCAS 2-3 months back. So
Okay.
the dysphagia was a part, and patient was admitted uh, under a specialty for dysphagia, endoscopy, and everything was done, which was fine. Now, this patient also was under the specialty of gastro because he had transaminitis.
Okay.
Now, these are the two things which he had, but the most important point what he had was proximal weakness, which was missed clinically.
Okay.
So
Okay.
I always feel that transaminitis should give us one look to look at the proximal weakness because that
Okay.
comes from the source. So
Okay.
the raise LFT with everything normal, one I
Yeah.
always think of myositis.
Yeah.
So that I
The
learned for,
AST part.
yeah,
Yeah.
definitely. So
Yeah.
that is one I think what I feel very important. And second in the scenario,
Yeah.
specifically in sometime ICU or ward, where we have a
Yeah.
PUO case where fever is very high,
Mm-hmm.
leukocytosis is there,
Mm-hmm.
thrombocytosis, maybe CRP is sky high. And if
Mm.
with that also if transaminitis is there, it is very good clue to adult onset still disease.
Correct. Correct.
So this
Yeah.
two I keep catching because I get reference
Yeah.
only after everything is done.
Correct. Correct.
Yeah,
Correct.
but
Yeah.
these are
Yeah.
two. I still feel that it helps us.
Yeah, correct, true. The AST part coming from the muscle, coming from the
Yes, yes,
RBC, I actually didn't emphasize it because even in a hemolytic anemia, your AST can be abnormal. Right?
yes,
And any muscle disorder, AST can come out of the muscle. Okay.
yes.
And the ALT to some extent will be raised. So we really need not think that it's a liver problem. Right.
Right,
Okay.
ma'am.
But it's a big topic. I just
Yeah,
went through. I don't know if I was too fast, but I finished.
yeah. So it was very good learning, and we
Didn't
could
want to go
correlate
on
with
for
our
too
clinic.
long. It's
Yeah,
almost an hour.
yeah. Thank you, ma'am.
Yeah. Okay. Right. Okay. Thank you all. Thank you all
Yes,
very much. Okay. Okay. Somebody said about septic. This thing they said in sepsis you can get it's a multi-organ dysfunction, so you can get a bilirubinemia, you can get an AST/ALT raise. Okay, and we cannot really comment on the this thing because sepsis can involve any organ, and if you look at the SOFA score, then you would get the liver also being involved, but nothing specific. The only thing is you can get an acute cholangitis in an ICU because of, especially in a diabetic, it can be a killer, and if it is not diagnosed, patient can become very sick. That's all I have to say about sepsis and the liver. Right? Okay. I think we will conclude. Okay. Thank you all. Bye.